what are the lessons learned in our program? For patients, the importance of follow-up imaging even if their initial screen is negative. Again, studies have shown that patients who have small, seemingly benign findings in their initial screen who show up later for the follow-up screens, those nodules turn out to be malignant. But if we can't get the patients to come back, we'll never know that. We also need to educate patients about the smoking cessation programs. The studies have shown that getting people to quit smoking will save more lives than lung cancer screening. For the physicians, being sure that they understand inclusion and exclusion criteria and following the radiology recommendations for follow-up imaging, not imaging too early or imaging too late or not at all. We also need to come up with a plan to have dedicated staff to perform this follow-up monitoring. We also need the physicians to realize that low-dose lung cancer screening is not a substitute for diagnostic imaging. Scheduling. Scheduling and finance need to be completely aware of what is inclusion and exclusion, determining of exam appropriateness, and scheduling them accordingly. Again, making sure that we provide clear and crisp information to them about how payment is going to work. For the staff and the staff technologists, they need to understand inclusion and exclusion criteria, be sure that they're completely familiar with the imaging protocol, perform the correct follow-up, and work closely with the radiologist. It is unfortunate to say that in some situations we have had patients who have had an initial lung cancer screen present for their follow-up and be scanned at full dose with X-ray contrast. This is just clearly not indicated and shows a lack of understanding of how lung cancer screening works, and is something that needs to be addressed with your staff. Another lesson learned is that patients will be less than truthful. They will be less than truthful about their smoking history, their previous imaging history, their overall health history, all in an effort to potentially avoid high out-of-pocket costs. As an example, 2 weeks ago, I had a site call me who had performed a lung cancer screen on a patient under their initial screen. They met all the criteria according to their screening questionnaire, and a week later, after the patient had her lung cancer screening, she presented back to that site where she had her initial lung cancer screen, handed the technologist a CD of a study she had 6 months ago, and asked if we would do a comparison. Things like this do happen. Database management. Although the ACR recommends, or the ACR is building a lung cancer database or a lung cancer registry, there will be many other options for lung cancer registries. You'll have to choose one that best suits you and maintain that data in that registry. This is a CMS requirement for reimbursement. We need a robust data management system, something similar to MQSA, and we need staff to manage it. It's not about just hanging up a sign. If you're going to have a lung cancer screening program, I would suggest you try to keep your program manageable. Make it a real program and include every aspect of that program in a visit. Imaging and interpretation at the point of service. Offer a pulmonology consultation that face-to-face with that physician. Pulmonary function testing and referral to that surgeon if indicated. Smoking cessation counseling and follow-up visit scheduling. If you can do all of these things in one visit prior to the patient leaving, the likelihood that you will lose patients to outside sources or lose them at all can possibly help. You would like to keep the patients in your system, and you will really need a nurse navigator to help you do this.